Hi, everyone. Thank you for joining us. We'll be starting shortly. At this time, I would like to invite you to add your name, your location that you're joining us from, and your organization in the chat. Okay. So welcome, everyone. We'll go ahead and get started. I want to thank you for joining today's session. Today's webinar is the first session in a 7-part national webinar series hosted by the National Alliance for HIV Education and Workforce Development. This series is in partnership with the AIDS Education and Training Center program and the Opioid Response Network. My name is Liz Lazo, and I am joined today by NAHEWD's president and principal investigator on this project, Dr. Daria Bakker-Lattimore, and our treasurer and co-principal investigator, Vanessa Carson-Sasso. This session is being recorded and will be made available as a resource on NAHEWD's website within 1 week. Please use the chat to engage with one another. We want to thank everyone for putting in their name, the location they're joining from, and their organization. So please continue to use that chat for that format. Throughout the presentation, if you have questions, there will be a Q&A pod that we do ask that you enter your questions into there. And towards the end, our speaker will start addressing those questions. So just to give a little background on NAHEWD, NAHEWD is a membership organization of 8 regional and 2 national AIDS education and training centers, also known as the ATCs, that support the HC program. Mission: established in 2010, NAHEWD supports the ATCs as a component of the HRSA-funded Ryan-White HIV/AIDS program, which have an explicit directive to build and maintain a well-directed, well-educated, and culturally sensitive health professions workforce that can provide prevention, diagnosis, and care and treatment and medical management for people at risk for and living with HIV. NAHEWD collaborates with multiple organizations in order to promote and educate the work of the ATC program. So with that said, we are also partnering with the Opioid Response Network. We want to thank them for the opportunity to have this program today through that funding with SAMHSA. Since 2018, NAHEWD has been funded by the American Academy of Addiction Psychiatry as a partner organization of the Opioid Response Network to address the intersection of HIV and opioid use disorder. ON was created to support efforts in addressing the prevention and treatment and recovery of opioid use disorder. ON provides free resources and technical assistance locally in communities across the United States and its territories. Please visit the ORN website for more information or to submit a request for technical assistance. So we are happy to offer CME, CNE, and social work credits for today's session. There will not be any partial credits. You will need to attend the full session in order to request your credits. We ask that you please complete the post-evaluation survey that will be made available we'll put that link in the chat towards the end, and it will also be emailed to you within 1 day. We ask that in order to request the credits, CME, CNE, social work, and/or a certificate of attendance, that you please complete it within 1 week. After that, you will receive your certificate through email within about 2 weeks of completing the evaluation. But we would love your feedback, as this will be an ongoing series on the second Friday of each month from starting today through January. So we would love to have your feedback as we continue on through our series. And also in terms of for accreditation, we do ask that you change your name to reflect the name that you use to register. That would be super important for us to be able to ensure that you do receive your credit for participating today. So again, as mentioned, we will email the certificates within 2 weeks of you completing the evaluation, and just to ensure understanding that it is your responsibility to know which CEs work for you in your state. So at this time, I would like to introduce our speaker, Dr. Chris Bositis, who works at the Greater Lawrence Family Health Center in Lawrence, Massachusetts, where he is a clinical director of the HIV and viral hepatitis programs. So Dr. Bositis, I am going to pass it on to you, and we want to thank you for being here today.
Thank you so much. Thank you, Liz. Thank you, Vanessa. Thank you, everybody who was part of organizing this webinar series together, for inviting me to speak. Whoops. And let's see here. Sorry for the logistical issue with my slides. I'm going to try to pull it up from the very beginning there. All right. So again, my name is Chris Bositis. I'm coming to you today from a very rainy Lawrence, Massachusetts. If there's a lot of background noise, it is the rain hitting the roof right above the room where I'm speaking from. So I have no specific relevant financial relationships during the last 12 months to disclose. And I'm really happy to talk to you all today about integrated care for individuals living with HIV and substance use disorder. To give you an orientation to the structure of the talk today, I will start by discussing a little bit of background information. We'll go over some of the epidemiologic data on the overlap between the HIV and substance use disorder syndemics, as well as data that describes the impact of these coexisting disorders on specific patient-oriented outcomes. I will then move to describe the integrated care model for individuals living with HIV and substance use disorder. We'll talk about some of the basic components that are common to all integrated care models, as well as some of the data that supports this model of care for wider implementation. And then in the last part of my presentation, I will discuss the specific integrated model that we have developed here in Lawrence to provide mobile care for individuals living with substance use disorder and who are HIV infected or at risk for becoming HIV infected. My hope is that from an educational objective standpoint, by the end of the presentation, you will be able to describe some of the recent epidemiologic trends in HIV incidence among individuals who inject drugs, including disparities based on gender and ancestry, that you will be able to describe 2 to 3 components to low barrier integrated HIV and SUD care, and that you'll be able to identify 2 to 3 challenges to successful integration, as well as potential strategies to overcome those challenges. So let's start with the data, and we'll talk about epidemiology first. I'm going to start by reviewing slides that I think most of you are probably familiar with. These are the very disheartening slides that show that since 1999 in the United States, there has been a 3.5-fold increase in the number of individuals who have died as a result of a drug-involved overdose. I want to highlight here that although it looked like in 2018 we might be making progress, whatever progress we saw there has been reversed in 2019. And while we're still waiting for the final data from 2020 to come out, preliminary estimates from some sources suggest that as many as 90,000 individuals died in the United States in the year 2020 as a result of a drug-related overdose. The vast majority of these drug-related overdoses in the United States are the result of an opioid overdose, over half, as you can see here. Although they don't affect men and women similarly, you can see that there has been a significant rise in members of both sexes in terms of their the risk for, or the number of overdose deaths occurring over this time frame. The acceleration in overdose deaths in the United States has really occurred most dramatically since 2013, 2014. And that recent acceleration has been fueled in large part by the introduction of fentanyl into the drug supply in this third most recent wave of the rise in overdose deaths. Now, when we think about the impact of an HIV diagnosis and how that specifically interacts with an individual's risk for experiencing an overdose, we are accumulating data that suggests that HIV itself, in some way, shape, or form, increases an individual's risk for an overdose. There was a meta-analysis published by Tracy Green and her colleagues back in 2012 that revealed that having an HIV diagnosis increased an individual's risk of a fatal overdose by 75%. And although the causal mechanism for this relationship was not really apparent, it is likely that multiple different factors are at play, including biological factors, psychosocial factors, and structural factors. More recent data presented at CROI in 2019 looked at this issue from a different perspective. What they did is that they analyzed the risk of death in individuals with an HIV diagnosis between the years of 2011 and 2015. And what they found was that although the overall risk of death decreased by 10% in this population, that the number of deaths attributed to a drug overdose had actually increased by 43%. And even more recently, in a study out of San Francisco County, that was a prospective postmortem study looking at out-of-hospital deaths attributed to sudden cardiac death. What they found there was that individuals with HIV who were identified as experiencing an out-of-hospital sudden cardiac death, 34% of them had actually experienced an occult drug overdose. And that was compared to 13% of individuals without an HIV diagnosis who were also in this study. So while we can see that having an HIV diagnosis appears to put one at an increased risk for experiencing a drug overdose, and particularly a fatal drug overdose. We also know and have known for quite some time that using drugs, and in particular injecting drugs, puts individuals at a higher risk for becoming HIV infected. And after years of progress in terms of reducing incident HIV infections among those individuals who do inject drugs in the United States, we have seen a disheartening reversal in this trend. And in 2018, 10% of new HIV diagnoses were attributable to injection drug use. This trend reversal has largely been the result of localized outbreaks in injecting communities throughout the country, and those outbreaks have occurred in such geographically diverse areas as Northeast Massachusetts, from where I am speaking today, all the way to Alaska, and many, many places in between. Digging into the epidemiologic trends a little bit deeper, I want to highlight this slide from the CDC that looks at trends in new HIV diagnoses, both by sex and by race and ethnicity. And there are a couple of interesting things to highlight here. First of all, you can see that new HIV diagnoses among men who inject drugs has been fairly stable over time from 2014 to 2018, although the number of new diagnoses, incident diagnoses of HIV has increased in women. So this appears to be disproportionately impacting women. Interestingly, when we break it down by race and ethnicity, what we see is that there has actually been a decrease in incident HIV infections among persons of color who inject drugs, but a fairly sharp increase among incident HIV infections among white individuals who inject drugs. But I want to pause and say I don't think that this tells the whole story. In fact, I think the cynic in me would argue that a big reason why we are now focusing so much attention on these overlapping syndemics, which have been devastating our communities for decades, is only because it now is impacting the white community. When we look at the data a little bit deeper, we can see, whoops, sorry, hitting the wrong button there. We can see that there are really significant disparities in the lifetime risk of HIV infection for individuals who inject drugs based on gender and race or ethnicity. So for example, while the lifetime risk of a white male who injects drugs becoming HIV infected is approximately 1 in 100, the risk for a Black male who injects drugs in the United States becoming HIV infected during their lifetime is 10 times higher, or close to 1 in 11. For women, the disparities are actually even starker, with a 7-fold increased risk for Black women compared to white women who inject drugs becoming infected with HIV during their lifetime. And these are significant disparities that need to be addressed. So moving now from the epidemiologic data to the impact of substance use disorder on patient-oriented outcomes. When we do a review of the literature, what we find is that overall, the data suggest that rates of engagement, retention, and viral suppression are likely lower in individuals with active substance use disorder compared to the general HIV infected population. But I want to make a pause and make a couple of points here. One is that the data are actually quite variable, and we know, as exemplified by the graph that you see at the bottom of the slide that there are segments of the population, women in particular, who have HIV-related outcomes that are quite similar to the general HIV-infected population. So in other words, women who inject drugs, who are infected with HIV, have rates of engagement, retention, and viral suppression that are quite similar to the general HIV-infected population. Also, it's also really important to note that abstinence from drug use is not required in order to achieve successful antiretroviral treatment-related outcomes. Again, you can see that in the graph from the CDC at the bottom of this slide. But I really want to emphasize that while historically active substance use disorder has been used by some providers as a reason not to prescribe antiretroviral therapy, I do not think that the data support this approach. I think that we know that people who, even people who are actively using drugs, can successfully achieve virologic suppression, although there may be some truth to the speculation that individuals who use more drugs are less likely to be virologically suppressed. So given all of the information that I've just presented, given the disheartening trend toward more incident HIV infections among individuals who inject drugs, as well as trends toward lower rates of engagement, retention, and virologic suppression among those with active substance use disorder, I think we can argue that urgent new models of care are urgently needed to reverse these trends. And the specific model of care that I want to flesh out in a little bit more detail in this next section of the talk is the care integration model. And before I go there, I do want to highlight the fact that a harm reductionist approach goes hand in hand with the integrated care model to provide person-centered HIV and substance use disorder care for the members of our community who are suffering from these conditions. I have this slide that highlights some of the basic principles of harm reduction, what the definitions of those principles are, and what the practical applications of those are. Here really is a reference slide. I'm not going to go over each one of the principles in detail because I think we could actually spend the majority of this presentation doing that if that's what we chose. But I have it here for your reference, simply because I can tell you that from my own personal experience, it has been really helpful for me to go back to over and over again as a reminder for what harm reduction is and what it isn't. Because the reality is the work that we're doing is often hard and it can be frustrating. And so reminding myself of these principles and what they mean and how they should impact how I deliver care to the people that I'm serving has been really helpful for me in practice. Now, I want to transition and talk a little bit about what I think some of the key interventions related to this harm reductionist approach are in practice. And I think that there are really 5 that I want to highlight that I think we really want to try to implement as widely as possible in our effort to address the overlapping HIV and substance use disorder syndemics. Overdose, those 5 are overdose prevention, prevention of infectious complications, pharmacologic treatment of substance use disorder, outreach and education, and lastly, supervised injection facilities. And specifically, I want to highlight for those of you who are not familiar with the publication called Getting Off Right by the Harm Reduction Coalition. This has been an invaluable educational tool that I have found in my own practice to help help the people that I am seeing in the mobile health unit learn how to inject more safely. The link is there. It is really a really helpful practical tool for use on a daily basis for those who are actively injecting. And the reason why I've picked these particular harm reduction interventions as being critical is because we have really good data that they work. We know, for example, that naloxone distribution significantly reduces the risk of the rates of overdose in communities where it occurs. We also know that that pre-exposure prophylaxis reduces the risk of HIV infection among individuals who inject drugs by as much as 84%, depending on how you look at the data. We know that syringe service programs substantially reduce the risk of HIV infection, overdose death, while at the same time increasing the likelihood that individuals who participate in SSP programs will get enrolled in treatment for their SUD, and it increases public safety without increasing crime. Supervised injection facilities, while not yet a reality in the United States, have shown similar positive outcomes in those communities where they do exist. So I think that is something that we should aspire to, an intervention that we should aspire to here as well. So with that one pillar now in mind, that pillar of harm reduction in mind, I do want to move and talk more about the care integration model for individuals living with HIV and substance use disorder. I want to highlight the fact that many of the descriptive factors that I will be discussing related to the care integrated model come from a publication from Dr. Judith Feinberg and her colleagues back in 2018, where they looked at successful models of integrated care throughout the country, really recognizing the need for new models if we are indeed to successfully tackle the overlapping syndemics of opioid use, HIV, and hepatitis C. And what they found in these different clinics throughout the country is that they all had a number of features in common that really promoted this idea of integrated care. They all provided substance use disorder treatment. They all provided access to treatment for HIV and hepatitis C. They all provided access for behavioral health services, as well as access to pre-exposure prophylaxis. And lastly, they all provided access to other harm reduction services, such as SSP and overdose prevention. However, I also want to emphasize that not every integrated program will look the same. There will clearly be differences in what a specific integrated program looks like based on the local needs of the population, as well as whatever local resources are available to meet those needs. Moreover, the clinic program and structure, as well as staff and clinician training and experience are likely to have a significant impact on what the actual model of care looks like in practice. I think that the reason that this model of integrated care is so appealing comes from data that we have known for a while on the impact of treatment for substance use disorder on HIV treatment outcomes. So for example, we know that individuals with substance use disorder who are receiving treatment for their opioid use disorder are significantly more likely to be prescribed ART, to be taking their antiretroviral therapy, and to be virologically suppressed compared to those who are not on treatment for their opioid use disorder. And so I think what the care integrated model does is it says, hey, we want to break down whatever barriers might exist to accessing that treatment for opioid use disorder or substance use, whatever substance use disorder you're experiencing, so that you too can experience the benefits, the downstream beneficial effects when it comes to the treatment of your other conditions like HIV. And we're seeing that this integrated care approach has benefits not just for people living with HIV, but also for people living with hepatitis C. These data, which were presented at the AASLD meeting last fall, looked at, actually compared the integrated care model, which they call the embedded treatment model, with a more traditional referral-based model, which they call the embedded HCV navigation model, as two different approaches to hepatitis C elimination in the city of Philadelphia. And before I show you the outcome slide from this study, I want to highlight the fact that participants who actually were in the embedded treatment model or the integrated care model, as I like to call it, were actually significantly more likely to be currently using drugs, to be homeless, to have ever experienced incarceration or ever experienced an overdose, compared to those who were in the referral or embedded navigation arm. And all of those you would think would put individuals at higher risk of worse outcomes, worse treatment outcomes. But in fact, what this study showed was just the opposite, that individuals who received their substance use disorder care and hepatitis C care through the embedded care or integrated care model were actually significantly more likely to make it to the next step of the care cascade at every step along the cascade, all the way through treatment completion, with 58% of those in the integrated care model completing treatment compared to just 16% of those who were in the referral-based model. So I'd now like to just shift gears and talk more specifically about the integrated care model that we in Lawrence developed to address the needs of our community, and specifically the needs of those individuals who are experiencing homelessness, substance use disorder, and who were either newly diagnosed with HIV or who were at risk for becoming HIV infected. And the specific intervention that I'm going to talk about is our mobile buprenorphine treatment program. And what you see here is a picture of our mobile health unit. This intervention was born out of an outbreak of HIV that we experienced here in Northeast Massachusetts. And what you see here are data from the CDC's EPI-AIDS investigation, which found that between the years of 2015 and 2018, there were nearly 130 new HIV diagnoses in Northeast Massachusetts who fit the case definition criteria, the vast majority of whom, for whom the risk factor for HIV infection was injection drug use. Another really important point to make about this particular outbreak is that in the CDC EPI-AIDS investigation, they found that of all of the individuals that they interviewed as part of the investigation, 100%, every single one of them reported experiencing homelessness during the previous 12 months. So we realized that in Lawrence, we were actually having a really tough time engaging many of the individuals that had been identified as newly HIV infected through this outbreak. And so we decided to step back and reevaluate our care delivery model. And what we found was that even though we had multiple different programs in place that we thought should address all of the different needs of our community members, we actually found that from a patient perspective, it was not always easy for them to get the services that they needed when they needed them at that point in time. And so we decided to step back and restructure things to allow for more comprehensive integration of our programs, personnel, and patient care. And from a programmatic perspective, what that meant was that we brought all of the different special population grants that we were receiving under one umbrella of leadership. And that meant everybody who was in all of the different grants that supported these programs, from our Ryan White HIV funded grants to our DPH funded prevention grants and our DPH funded addiction treatment grants. All of those were brought under the same management umbrella so that we could then we could then be flexible as much as possible with this funding. And moreover, we initiated regular combined team meetings with members of all the different teams where high-risk patients from each of these different programs were reviewed so that everybody would be aware of them. And most importantly, we adopted a common vision for low barrier harm reduction integrated care for the members of our community. From a personnel perspective, what this meant was cross-training our nursing and case management staff in all of the different aspects of our many different programs so that they could provide the patients that they were seeing with the services that they needed without adding barriers of referrals and extra visits. And similarly, the clinicians who are providing care on the mobile health unit were all trained in substance use disorder. They were all trained and comfortable prescribing post and pre-exposure prophylaxis for individuals who are at risk for HIV infection. And they were all able to provide HIV primary care for those who are already HIV infected. And then from a patient care perspective, what this meant was that we actually brought the care to our patients to the locations where we were most likely to see them. And we emphasized, again, this harm reduction model where everyone would be offered overdose prevention, HIV treatment or prevention, infection prevention, and then treatment for their substance use disorder if they so desired. And when we put all this together and stirred it up, what we got was what we call our MHU Magic. Just to describe what we do, we through trial and error, we have decided that the best location for our mobile health unit is actually in the parking lot right next to our syringe service program. Although sometimes we also park it around the corner, just about half a block away, right outside one of the day shelters in Lawrence that many of the community members use. And what this does is that it enables the community health workers who are staffing that syringe service program and who know the individuals who are utilizing those services the best, to engage them in conversations and assess where they are at in terms of their stages of change. And for those who are actually ready to seek treatment, they just refer them right to the van when it's there. And if they're not ready to seek treatment for their substance use disorder, but they need treatment for something else, a skin or soft tissue infection, for example, we're there for that as well. And so, again, we are there for whatever need the patient may have, whether it's primary care, treatment of their substance use disorder. We have case management staff who are there and available to help individuals with their insurance issues. If what they want is getting detox placement, they help with referrals for that. They can help with shelter and housing referrals. For individuals who would like treatment for the hepatitis C, we are providing that on the mobile health unit now as well. And we also have Ryan White funded case management services co-located at our SSP site for individuals who are HIV infected, so that they can get on-demand assistance enrolling in the HIV drug assistance program and the other services, care completion services that Ryan White is so great at providing for individuals living with HIV. So I'll begin to bring this to a close by reviewing our data, to answer the question, is this integrated care approach working here in Lawrence? And so just to give you a little bit of background, in 2018, we identified a key group of 29 individuals who had been diagnosed with HIV through this outbreak, who were also experiencing housing instability and who were actively suffering from substance use disorder. And we found that before this intervention was implemented, that only 38% of them were actually engaged in care. With the intervention of the mobile health unit, we were able to engage an additional 12 HIV-infected patients in care. And when we analyzed the data in December of 2019, we found that 81% of them remained engaged in care. You'll see that the denominator is slightly smaller than the N of 29, and that's because unfortunately two of those individuals had died. When we broke it down, looking at just those individuals receiving care on the mobile health unit, all of them had been prescribed antiretroviral therapy. 2/3 of them were virologically suppressed, and 75% had been started on treatment for their substance use disorder with buprenorphine. And an additional 3 were also linked to or continued on methadone treatment. COVID really had a significant impact. It really kind of blew things up in our faces, unfortunately. And we looked at the data in March and they were terrible. We had very few patients who were actually still engaged, but as we have opened up since COVID, we started our mobile health, our in-person mobile health services again in May of this year. And I'm happy to report that as of July, that we now have 48% of our patients that were identified previously as part of this cohort who are actually engaged. And of the 13 that are engaged, all of them are receiving antiretroviral therapy. The majority of them, 54%, are virologically suppressed. And the 85% of them are are actively receiving treatment for their opioid use disorder. So although we still have significant room for improvement here, things are getting better as we open things up. I also want to highlight our data around pre-exposure prophylaxis. I've emphasized that this is one of the many different integrated services that we try to provide on the mobile health unit. And to put things into context, we know that individuals who inject drugs historically have not accessed pre-exposure prophylaxis much at all. In fact, there is some data. There were data that were presented at CROI a few years ago that suggested that of all of the individuals in Washington, D.C. who were eligible for pre-exposure prophylaxis based on their injection drug use, less than 1% had actually ever received a prescription for pre-exposure prophylaxis. So we know that this is a huge area of need, and that there's a huge gap here in terms of putting PrEP into practice for this population. With that said, what we've found is that we're doing an okay job. About half of the patients that we screened on the mobile health unit who were not already HIV infected were offered pre-exposure prophylaxis. Only about 11% of those actually started. And when we last analyzed the data with any kind of rigor, only 3% were still actively taking their pre-exposure prophylaxis, unfortunately. So again, still room for improvement, but I think better than some of the historical data that we have to compare it to. Now, having said all that, I want to acknowledge that implementing the an integrated model of care is not easy. There are many different challenges at the patient level, at the staff level, and at the administrative and structural levels. But I do think that there are many different strategies that we can implement to overcome some of these challenges. So when we look at the patient level challenges, for example, we know that we're still not reaching everybody that we want to try to reach, in spite of everything that we're doing. And although we don't know all the reasons for that, we hypothesize that perhaps the double stigma of comorbid HIV and substance use disorder may be contributing to that, as is the hierarchy of needs, and just perhaps individual readiness or lack thereof to seek care. And I think in order to address these particular challenges, we just need to continue to be present. We need to be there in the community, offering low barrier patient-centered care and affirming and addressing the hierarchy that patients are experiencing. From the clinician and staff level, it requires a lot of intensive training for our staff to become familiar with all the different programs so that they can truly offer integrated care. We also know that there's a significant tension that exists between the desire for recovery in the individuals that we're serving and the low barrier harm reduction model of care. This is complicated by the fact that we just don't have the behavioral health resources that we'd like to have that we think would really improve the outcomes that we're seeing in our community. In terms of specific strategies to address this, providing the staff with ongoing support through what we call clinical supervision or counseling with a trained behavioral health professional has been really helpful, as has reviewing that slide that I put up before on the principles and practical applications of harm reduction with an emphasis on the small successes that we're seeing in the patients that we're serving. And then lastly, there are some significant administrative and structural barriers to care integration. We all know that grant funding tends to be very siloed. The reporting requirements exacerbates the siloed nature of the many different programs that we have in place to serve our patients. But we found that with this particular challenge, knowing our allies was really, really helpful. And in particular, I want to highlight the enormous help that we received from our colleagues at the Department of Public Health in Massachusetts and the program managers there, who were really as flexible as the rules would allow in terms of how we were funding our staffing and the various programs that we were implementing on the ground to ensure care integration. There are other bigger structural issues like the X number and the legislative requirements for methadone treatment, stigma, criminalization, et cetera, all of which I think can only be effectively addressed through persistent and active advocacy on the part of the community and those of us who are serving the community as well. So to summarize everything this afternoon, I would argue that the ongoing opioid use disorder epidemic poses significant threats to the progress that we have made in reducing HIV incident infections among individuals who are injecting drugs. Sadly, there are significant disparities in that risk based on gender and ancestry or race. But I do believe that the integrated model of care approach is a promising one to address these syndemics by providing co-located integrated treatment for substance use disorder, HIV and hepatitis C, access to pre-exposure prophylaxis, behavioral health services, and additional harm reduction services, and removing the multi-layered barriers to care that our patients often experience. With that said, I also want to acknowledge that there are still some significant systemic and structural barriers that are in place, and that if we really want to have a lasting impact on reducing the negative health outcomes that we are seeing as a result of these overlapping syndemics, that we really need to advocate for systemic and structural change at the local and national levels. So I will end with that, acknowledging the many different people that were involved in helping us in Lawrence to put this particular integrated care model into practice. I'll take any questions that people might have.
Great, thank you so much, Dr. Vasitis, for that very insightful presentation and really showing us a look into your program and your successes. Such a great kickoff to the series. I want to say we do have 3 questions in the Q&A. Before we get to the Q&A, there was one question in the chat box I wanted to read to you from Robert Reyes. This hesitancy surrounding PrEP, is it because of provider stigma or bias, or the hesitance of the user to seek out providers?
My guess is that it's both. I think that, you know, in Lawrence on our mobile health unit, all of the providers are very comfortable with the data around the efficacy of pre-exposure prophylaxis for individuals who are injecting drugs. They're very comfortable prescribing it. They know what they need to do so safely. But I think that there is, at least in Lawrence, it may be, at least I'd like to think it's less of a provider issue I will say that one barrier that we hear frequently from the patient level perspective is that taking pre-exposure prophylaxis is perhaps an implicit acknowledgement of ongoing risk through injection drug use. And for individuals who are engaging in treatment for their substance use disorder, they want to put that behind them. They don't want to be reminded of that risk. They want to, it's like they want to make a clean break and say, okay, I'm engaging in treatment. And because I'm engaging in treatment for my substance use disorder, I no longer need pre-exposure prophylaxis. Although we also know that many of these same individuals would probably benefit from it from a sexual risk perspective, from the injection risk perspective. It's like a reminder that they don't want to have to have on a daily basis.
Great, thank you, Dr. Cyrus. We do have 4 additional questions in Q&A, and I know we only have about 5 minutes. I want to get through these as well. Sure. From Eric Moore, do your public health insurance programs, such as Medicaid, et cetera, pay for HCV medications? If so, will they only provide the medications once? How do you address these types of restrictions with those actively injecting drugs?
So we are really fortunate in the state of Massachusetts because we do not have, and we don't experience these restrictions. Medicaid does pay for hepatitis C medications. And they do not restrict treatment to one-time treatment for individuals who inject drugs. So we have not had to address those specific issues. I would encourage you, if you're dealing with those issues on a local basis, there's a great website out of Harvard Law School, and I can't remember the specific web address, but there is a great website that looks at these specific barriers to hepatitis C treatment and some of the specific legal arguments to help overcome these barriers. Yeah, in Massachusetts, we've been fortunate that we have not had to deal with them.
And from Malik Burnett, did you attempt to provide telemedicine-based services during the pandemic, understandably difficult in your patient population?
Yeah, so we did. We definitely provided telehealth for those that we could reach through the phone. You know, as you mentioned, it was sometimes difficult. Not everybody had an active phone number that we could reach. On the flip side of things, I will say that we actually ended up engaging a large number of new patients in our substance use disorder program, not all of whom are homeless, not all of whom are part of the same exact target population that we have for the mobile health unit. But in general, I think that we saw an increase in the number of people who were utilizing or who are accessing treatment for their substance use disorder through telehealth in the pandemic.
Okay, and do some of the reasons why people who were screened for PrEP were not being offered PrEP within your program, and do you have any solutions or strategies to increase PrEP offers?
Yeah, so I think the big drop off between those who are screened for PrEP and those who are prescribed PrEP, I think it comes down to a number of different things. One is logistical issues. Do we have a current HIV test on record? Do we have access to, and if not, do we have access to the testing? The reality is we're not doing venipuncture on the mobile health unit itself. We do it inside our SSP program. So in the same building where we have our SSP located, we do have a phlebotomist. But honestly, sometimes, you know, for patients who have just come from inside the building where we're providing the SSP, going back inside for their blood draw is just one other barrier. And so it doesn't always happen. And so it can be hard to get the necessary screening labs you need before you initiate PrEP, and there has been reluctance on the part of some providers to actually prescribe PrEP without any of that basic screening done, understandably so. My personal approach has been to prescribe it for very short periods of time without the testing, but I'm only comfortable doing that for a couple of weeks before we need to get that baseline testing and continuing it. I think, as I mentioned before, there are also patient-related factors. Patients sometimes just they don't want it for a number of different reasons, whether it's because they don't feel that they're at risk for becoming HIV infected. There are other things that they want to prioritize first. They don't always want it, even if it's offered.
Now, besides, we are at the top of our hour at the end of our session, but we do have 2 additional questions. Would you have time to answer these last 2 questions?
I do, if people are willing to stay for the last 2 minutes.
Okay. So we do have a question. Would there be any 3 algorithm testing, such as further HIV tests using other test kits done on those taking PrEP?
So I'm not sure I understand the question entirely. Let's see here. But we don't have rapid testing available, if that's what you're asking, and that is something that we're looking to try to implement. We do provide on-site testing through our SSP program for patients who are interested, and for patients who are already on PrEP. The follow-up testing is provided in the same way, through the phlebotomist that we have at our SSP site. And in terms of the last question, what type of healthcare professionals do we have at our mobile health unit? We have the community health workers, case managers, and clinicians. We do not have behavioral health specialists. We do not have peers or recovery coaches live, but we do have access to recovery coaches for patients who are interested through telehealth at this point in time.
Great, thank you so much. So again, Dr. Besides, we really want to thank you for your time and for your expertise and being a speaker in today's session. We hope that everyone enjoyed. We do ask that you complete the post-webinar evaluation. I added it to the chat. We also ask that you join us for the next session in our series, which will be next month. I have put that information in there. You can also go to our website. It will be on Friday, August 13th at the same time, 12 p.m. Eastern time. You can find more information on the NAHEWD.org website. So again, we want to thank our partners, the AATC program and the Opioid Response Network, and we wish everyone a great day. Thank you for participating.
Thank you so much.
Great job. Thank you. I think we can stop recording, right?